Good morning, everybody, and welcome to this session on evolving concept of mechanical ventilation. And on behalf of my co-chair, Peter Ribbensberger, I think we can fairly say that we have a very exciting session with two very mesmerizing speakers. And without any further ado, let's start with the first talk by Guillaume Emeriot from Montreal, Canada, talking about self-inflicted lung injury. Do we have any evidence for it in children and neonates?
Good morning, everybody. Thanks for the introduction and thanks for the invitation again. And I'm really happy to talk about this very hot topic, and which may be a bit difficult to deep dive in infant and neonates, and you will see that there are not so many data, sadly. So before going to the CLE and the patient self-inflicted lung injury, we have to remember that what's the VLE, ventilation-induced lung injury, and of course I know that most of you have read these papers and this concept, and I think it's always very important to keep in mind the concept of baby lung, decreased CRF, and in fact the hugely importance to maintain a small tidal volume, which is related to the size of the baby lung, and that's the thing which we have to keep in mind all the time. If you give too much volume in a small functional lung, of course you generate some strain, the deformation of the volume of the alveoli that directly generates the VLE, the ventilation-induced lung injury. So there is a difference between stress and strain, but overall this relates to the same concept. The strain is more the volumetric deformation. The stress is the action of the pressure that open the alveoli, and so the stress is more reflected by the transpulmonary pressure, the pressure that's supplied on the alveoli wall, and of course the two goes together. So how to minimize the risk of VLE? And I will be very brief. You have seen a very good presentation yesterday by Professor Amato on this topic, but to keep the thing very simple, just maintain the lung open with recruitment and PEEP, minimize the strain. So keep a low tidal volume, and the lower tidal volume you have to give when the CRF is the lower. And how to ascertain that the ventilation that you give is effectively protective? That's where you need to measure and to check what you're doing, and that's where the driving pressure is very important in my mind. So if you observe that your driving pressure is above 14, 15, whatever the threshold you think, but probably around these targets. If you're above that, this means that your your functional lung is too small for the tidal volume that you are giving, and you should consider giving a more protective ventilation. It could be adapting the PEEP, the positioning of the patient, the tidal volume, but you have to do something to try to minimize this impact. And so we have to keep in mind that the lung is the tidal volume that you give to the lung is generated by the transpulmonary pressure, and the transpulmonary pressure, you know that it's the combined action of the ventilator and also from the infant or the children action, which when he take a breath will decrease the pleural pressure. And so the transpulmonary pressure, you know that it's the difference between the alveoli pressure and the pleural pressure. And so a baby in NIV, you see on the bottom right of the slides, a baby on an NIV, if you give him a CPAP of 10 and it generates 15 centimeters of water of depression in the pleura, the patient will receive 25 centimeters of water of transpulmonary pressure. So if you intubate these patients, you will have to give 25 centimeters of water of a driving pressure to give the same tidal volume. Overall, it's not as simple, but it's the principle. And so it means that if you do not do this transpulmonary, if you do not give the pressure with the ventilator, that does not mean that the patient does not do the job himself. I mean, the impact on the lung is the same. So it's very important to keep that in mind, because the ventilator gives you the numbers of what it's doing, but you don't see what the patient is doing. And the transpulmonary pressure is directly correlated with the lung strain and the risk of VLI, so very important. And in that context, the notion of CLI, patient self-inflicted lung injury, has been reintroduced relatively recently, especially by Laurent Brochard and his team, but also several experts. And this was based mainly on the physiological rationale. In fact, that the transpulmonary pressure is associated with VLI, and the patient himself can generate the transpulmonary pressure. So there is a risk. And there are some supportive data. You have seen yesterday, a lot of animal studies have shown that vigorous spontaneous breath can induce some VLI, some CLI. It's also important that it's not exactly the same type of lung injury, because it's the fact that it's generated by the muscle of the patient, the diaphragm. It's not exactly the same area of the lungs that are injured, but also the vascular side of the capillary, of the alveolar barrier is probably more impacted with more edema, and that may be some differences between VD and CD. And other supportive data are that the fact that the use of NMBA has been shown to improve the outcome in Papazian study, and also that during NIV, the patients that take that larger tidal volume have a more complicated outcome. So these are indirect evidence supporting the concept of CD. And you've seen yesterday that Pendeluft can be also observed when we measured it, when we measured the ventilation with EIT, for example. So if we think a bit more about this concept, this rationale, this supportive data, of course, Papazian study has shown a dramatic improvement in when using neuromuscular blockade. But we have to keep in mind that the ROSE trial a few years ago has shown the opposite, so no benefit of neuromuscular blockade in ARDS patients, in adults. And of course, there were differences between these two studies, and maybe in ROSE trial, the patient received higher level of PEEP that may have mitigated the risk. But it's important. This means that it's not so obvious that all patients should be paralyzed. And other contradictory evidence also comes from this paper for the lung-safe observational study, also conducted in adults. It's a few years ago now. It's not the most recent paper, but it's interesting that they have reviewed in this cohort the patients that had some spontaneous activity and compared them to the patients that had no spontaneous activity. And you see that the mortality, in fact, was relatively higher in patients who had no spontaneous activity. So it's not always a crime, a drama when patient takes some ventilation, some spontaneous breath during support. But of course, this is an observational study, so probably the patients that were spontaneously breathing were different from the other patients and maybe less sick, and that may be one reason that they have a better outcome. You've seen yesterday this slide. The problem is that, in fact, the volume controlled does not prevent you to, or the patient to get injurious ventilation because of breath stacking, double triggering, and also Pendeluft effect. You can see on these two different EIT sequence. On the left, you have a patient who is completely ventilated, but with no spontaneous breath. And on the right, the patient participate in its ventilation, and you see that the same tidal volume moves within the lungs, and so the lungs, which may seem to be, you think the patient receives 6 ml per kilo, but the lungs receive 6 ml per kilo at one place at a time, and then at another place at a time. And so the strain will be much higher than what you expect. So this is the Pendeluft, and this probably exists in some circumstances, and this is clearly exacerbated by the spontaneous breathing. On the other hand, you also have interesting data, and this is an experimental data that compared negative ventilation versus positive ventilation in an animal model that was published in the Blue Journal last year. And you can see on that the curves, the PV curves on the top of the slides were different, in fact. And during inflation, the negative pressure ventilation was associated with a progressive earlier lung recruitment that may be indeed beneficial, in fact. So it's not that obvious that negative pressure ventilation is always negative, deleterious. There are also maybe some positive aspects, and in this study, the lung strain, the local strain was in fact decreased when the patient was spontaneously breathing. In fact, during the negative pressure ventilation as compared to the positive pressure ventilation. So it's not a very simple story, in fact. And we also discussed yesterday the Pendeluft effect. Does it exist in infants? To be honest, I had not seen this paper, so thanks Professor Amato to show me this one, because there's not a lot of data for Pendeluft visualization in children. And this is a case where Pendeluft occurred when they minimized the PEEP during a PEEP titration. So at lower level of PEEP, the patient developed this Pendeluft effect. But the team by Martin recently published this nice paper with EIT, and they analyzed the ventilation of the patient, of a cohort of patients, 35 patients, at different level of support and different mode of ventilation. What you observe is that on the right, that when they switch the patient on pressure support ventilation and they decrease the level of support, in fact, their center of breathing was moved to be more dorsal. So this may be good or bad. In fact, this shows that the patient will use more dependent region. So this may be one of the things that may be associated with CD, but this also may be associated with recruitment. But interestingly, they did not observe Pendeluft in this cohort of patients who were maybe not very sick, but it's important that in common series of patients, it's not always the time. So one important question I think we have to keep in mind is, do the children and infants frequently adopt a high ventilatory drive? Because this is the place where it can be important. The CD can be problematic if it's when the patient have a high drive. And to be honest, I'm not really convinced. This is a study that I've done now more than 10 years ago, where I wanted to describe what's the ventilatory drive of the patient, so what's the level of EDI, in fact, the electrical activity of the diaphragm during a PQ state. These patients were not on NAVA, but we used the NAVA technology to measure the electrical activity of the diaphragm, which is a very good direct reflection of the respiratory center output. So this measured the drive. And what we observed is that as compared to post-extubation condition, you see that in the pre-extubation phase or in the acute phase, the patient has a very low ventilatory drive. We thought that these patients were breathing, but they were not very breathing with very high activity. And more than that, 18% of the time, we had no signal at all. So this means that they stopped breathing, which is completely abnormal for patients, but which is quite frequent in our ICU. And so this is the common group. Is it, however, possible that some of these patients may develop a higher drive? And you see the little circle that shows that some patients had higher activity, of course. And this is another study where we looked at the patients who were ventilated in NAVA, because we use it quite frequently in our unit. And this is always the question, is the ventilation protective when patients are ventilated in NAVA? And you see that during the NAVA ventilation, the tidal volume that the patient obtain is 5.6 ml per kilo as a median, and with the upper quartile at 7.6. So it's overall, it's not very frequent that they take deep breaths, but it's true that the number of breaths that are higher than 10 ml per kilo is not that negligible. In fact, 8% of the period that we analyzed were associated with a tidal volume above 10 ml per kilo. Who are these patients with a tidal volume above 10 ml per kilo? They have an oxygenation index of 4, a pH of 7.4, inspiratory pressure of 20, and a delta pressure of 13. So should they be paralyzed? This is a discussion. I'm not sure. I don't think so, but maybe some of them could, maybe the sickest one. So these patients were not in PARD, so maybe this is different in ARDS. So I looked at the data from the PARDI observational study, and this was a sub-study conducted by Anupinda Bala from THLA, and where she looked at the tidal volume that was used in all the sites that participated in PARDI. This is an observational study, a large observational study, more than 700 patients. What you observed is that the tidal volume is about 7 ml per kilo. And interestingly, when you see the patient with high delta pressure on the right of the slides, like a delta pressure above 18 or above 22, this patient should have a lower tidal volume. And what they have is they receive a higher tidal volume or the same. And so we do not follow what we should do. In fact, and this is not the patient, this is the doctor. And so we do not adapt the ventilation to the patient condition, and this should be something we should consider. And this is especially true as the fact that to not respect these guidelines, these rules to adapt the tidal volume to be more protective when the ARDS severity increase is associated with worse outcome, with mortality. And this is the same for when we do not respect the PEEP recommendations. Another study that looked at the tidal volume that were generated during ARDS, and this was a study that was now from probably early 2000s, from Marco Piastra, who looked at we used NAVA during ARDS in children. So this was not the very early phase of ARDS. This was after the patients were transitioned from HFOV. And so they were weaned from HFOV to NAVA. And you see the same, the tidal volume that was adopted by the patients was 5.5 if the patients were transitioned to PSV, or 6.1 when they were transitioned to NAVA. So not a huge, not very large tidal volume. In NIV, this may be different in NIV in PARD, and this is an area where the PCD it's crucial to think if it's CD exists or not. Should we intubate this patient and give them more protective ventilation? And in fact, here you have this study of, this is also a sub-study of PARD cohort, and we explored the use of NIV in these patients. And overall, you see that when the patients were exposed to NIV longer than more than 24 hours prior to be intubated, so this is only in the intubated patients, so the failure rate in this population was quite high, about half the patients were intubated. And if you waited more than 24 hours, it's true that it's a small proportion of the patients, about 1/4 of the patients, but the mortality was higher in this subgroup. It's not significant because the numbers are not very large, but this is also confirmed by other studies. If your patient finally is intubated, probably it's not very good to be intubated too late. So you see that the majority of the patients were intubated within the first 6 hours, and they do not have a very high mortality in these severe patients. But it's probably something that could be associated with CD, and in fact, that's an indirect sign maybe. But overall, having exposed these patients to NIV is not associated to increased mortality. So if you deliver an NIV with relatively prudent process and intubate the patient if they do not respond, maybe you have it's a possibility. So you see even in the propensity score match comparison, the mortality and the ventilation duration were similar, and the trend was more in favor of being ventilated in NIV, but of course these patients were maybe a bit less sick. So I see the spontaneous ventilation in patients with acute respiratory failure like a balance. And of course, there are some advantages. We don't want to intubate all our patients. We don't want to come back to the patients. It has taken years not to intubate the bronchiolitis patient. I don't think we should intubate all these patients because they have some high ventilatory drive. But it's been, even during intubation phase, it may be good for the diaphragm function, for the lung recruitment, it's associated with less sedation and paralysis. But we have to keep in mind this risk of CD. And this is the concept of lung and diaphragm ventilation, which is really a fine balance. But if you want to get this balance in a good position, then you have to monitor what you're doing, and you have to monitor the drive, and it's not that easy. You've seen that we sometimes use diaphragmatic electrical activity. That's the way we monitor them in our sites, but it's not available everywhere. Some people will use plateau pressure, esophageal pressure. I will show you how we can do that. So just a reflection about how we can use EDI monitoring when we measure the drive. This is a series of patients that in our sites that were treated with NAVA, with NIV-NAVA for bronchiolitis, 64 patients over 2 years within a cohort of 200 patients. So about 1/3 of them, when they were failing CPAP or high flow, we switched them to NAVA. And in fact, you see that they have very high drive at the beginning. So like at least an important proportion of these patients, they have the median value was about 45 microvolts, which is a very high drive. But the important point is that after 1 hour, it decreased to 30, and 2 hours, it decreased to 25. So almost normalized their EDI. So it's important to check that your patient is improving. So if the patient stays a very high drive over time, and then maybe you get more worried that the CD could occur. So this is an example. Another maneuver that can be used quite simply at the bedside is to measure the plateau pressure. You know that usually we have all been trained with the concept that plateau pressure should be used with in patients who do not breathe or who is even paralyzed. But in fact, this is not true. This is a good way to monitor, in fact, the force which is generated by the patient, the pressure which is generated by the patient. So you have this example from a series that has been published also by CHLA group. And you see on the middle of the slide conventional ventilation, and then you apply an end inspiratory hold with the flow which is 0. And then when the patient relaxes, you see the esophageal pressure swing. When the patient relaxes with the 0 flow, the pressure, instead of decreasing when you use it in the patient who is not breathing, then the patient relaxes, so the flow will go out, and you will see an increase in pressure. And the plateau pressure that you will be able to measure when you reach a steady state will be higher than the inspiratory pressure during the conventional ventilation. But this is the true driving pressure that you should consider, you should take into account. So it's very important to remember that the driving pressure that you measure at the ventilator is only reliable if the patient is not breathing. If the patient participates, you have to do a plateau pressure and measure. So it's not always easy because our patients are breathing fast, and so having this plateau is not always very simple, but this is at least one way to do that. We can also measure the esophageal pressure swing and actually measure the transpulmonary pressure. This is done by some teams, but it's not really routine, it's more research. This is an example from Florent Baudin that he presented last year at EPNCIC in bronchiolitis, also in NIV. When we put them on CPAP, and we want to see they improve, but do they have higher or lower transpulmonary pressure? We give them 10 centimeters of water. If they improve, maybe they have a higher transpulmonary pressure because they continue to participate, or if they improve sufficiently, they will decrease their drive and they will have the same transpulmonary pressure. And in fact, these are a small number of patients. I don't know if they continue the study, but you see that the patients that had the highest transpulmonary pressure tended to decrease. So in fact, probably the addition of the external CPAP was probably compensated by the fact that the drive decreased. And so for this ventilation, diaphragm and lung ventilation, lung protective ventilation, we had this very nice, elegant pilot study that in fact applied this strategy in the patients, measuring the esophageal pressure, the swings, the effort of the patients, and they adapt the ventilation strategy to maintain some level of patient activity, but also making sure that this activity is not too high. So this was a pilot study conducted by Robinder Kemani's team and Kit News in CHLA. And you see that they have tried it in 32 patients in this pilot phase. They are not now in a phase 2 phase with a multi-center participation, and it's promising. In fact, you see that as compared to a historical cohort, so this is always a cohort controlled, which may be fragile, but they have a better evolution, which is considering the mortality or the ventilation-free days. But what we observe, in fact, is that as compared to the control group, the red vents, so the diaphragm and ventilation and lung protective ventilation, were exposed to lower driving pressure, lower tidal volume, relatively lower PEEP. And in fact, I'm not sure we really decreased their CD. In fact, we probably decreased the VLI. They decreased the invasiveness of the ventilation that they give. But they also maintain the patient effort in the controlled range. So to conclude, is there any evidence of CD in children? I think there's no direct evidence, except for the fact that it's true that some patients develop air leaks like pneumomediastinum, and this is an indirect side of the fact that the patient can develop CD. Of course, the pathophysiological rationale makes total sense, and in fact, there's no reason why CD would not exist, but it requires a major respiratory drive. And to be honest, I think that it's probably much less frequent than over assistance and than doctor-inflicted ventilation injury that we call VLI. And I think it's important to remember that if we want to avoid any case of CD that will be associated with a high risk of complication, oversedation, paralysis, invasive ventilation, that's not where we want to go. But in a few patients who have a high ventilatory drive, especially in the acute phase of an illness, like an ARDS, I've shown you example of bronchiolitis. It's quite easier in bronchiolitis because you know that the patient will improve. So you want to wait a few hours, but in ARDS, it can take days, and then you want to be maybe more protective. Then it's important to consider monitoring the patient effort and controlling the drive and ensuring the protective ventilation. But if you intubate a patient on NIV because of the CLE, then please adopt a very protective ventilation. We cannot think that we will do better than the patient and we then give them 8 ml kilo when they need 6 ml per kilo. And of course, this is a huge priority, I think, for research. How can we routinely monitor the drive? It's not easy. What are the safe thresholds? These are very important questions that we have to answer in the future. Thank you very much.
Thank you, Guillaume, for this fantastic talk. We have time for a few questions. Daniela.
Thank you very much, and this is inspiring. Obviously, we are a little bit limited in our reasoning because we rely on adult data. We have very few in kids and in neonates, and you said it all. I mean, we are all in love with NIV, maybe a little bit too much, at least some of us. And I have two questions, actually. I don't disagree with you. We're not going to go back intubating bronchiolitis babies that are just fine on CPAP or on NEVA. We all know that. I'm more concerned about those babies that may be under some sort of non-invasive respiratory support with a stiff lung, so sort of a ARDS or, almost like ARDS, like you said, with the new PALIC definition. Or even worse, former preterm infants with acute and chronic respiratory failure, right? So with a sort of a mixed situation with increased resistances and also stiff lung. And I wonder if we're doing more harm than good in these patients, also because they are relatively small, like 1 year or some months and so on. And the second question is probably more for Martin. Do you have any explanation regarding the absence of Pendeluft in this series? Was that because these patients were not enough stiff, were not enough thick?
So regarding your first question, thanks. I agree, and I think this is an area of research, to be honest. Bronchiolitis is an example where we don't want to go back, but in fact they have a quite high drive, and maybe in some of them we go too far, but maybe we don't want to go back too much. It's an open question. I think the PALIC recommendations for ARDS, when we take this part of your question, are quite prudent, and I think I believe in that. It's good. It may be good to try if the patients are not too sick, if they do not have other systemic failure, like if they have no unstable hemodynamic status, for example, or whatever. So if the patient is in a good condition to try, you can try NIV, but you have to reassess. And if you do not show an improvement in a few hours, it's said 6, but if it may be 1 hour if the patient is sicker, then some of them should be intubated. And I think we have to find a close balance. But 15% of these patients, even in the most severe strata, if they have no other risk factors, were not intubated, and they did pretty well. So I think there's a balance. For the chronic lung disease, I think this is a question that we have on a day-to-day practice, and I'm not sure I have the answer. In fact, we have the same questioning. We have these patients that came from the NICU at 4 months, 6 months, and they are on high flow and they have a very high respiratory drive. Is it better to maintain them on high flow, which is called non-invasive, but in fact I'm not sure it's non-invasive. The patient has nothing to do that trying to breathe, or should we just track these patients and give them some support and maybe some sedation at the beginning and let them recover progressively? I think this is a place where we should certainly do a research. A trial would be difficult because we all have only one or few kids at this, of this type, and this is decreasing with the progress that the neonatologists have done, so I think it's not easy. But for the second patient, I don't know, the question, I don't know if you want to answer.
I will discuss that with
Martin?
Danny over the coffee.
Yeah.
Any other questions?
When we talk about the respiratory drive and increased respiratory drive, we often do not discuss where it comes from. What is the cause? Is it increased elastic and resistive load of the system? Or is it because we just have a central problem with the patient, which we saw mainly in the COVID patients with pathological respiratory central drive? And when you measure now only the diaphragmatic activity, you can make out the difference without having transpulmonary pressure to see what is the real issue there when you're supporting the patient. So you showed the paper showed on NAVA versus pressure control that at the end with NAVA, the tidal volumes were larger, but on the bottom of the same graph, the descending pressures were much lower. So with the concept of proportional assist of NAVA, what we see is that if you have a patient with an increased respiratory drive and you start to proportionally support him, he goes down with his drives and he finds his tidal volume. And in patients with increased elastic drive and resistive drive, so the restrictive patients with a heavy load, they usually find their tidal for about 5 to 7 and not higher, and this in children as in adults. So do you think the concept of NAVA, however, might make sense and might be safer than adding a volume control as the adults do in these patients? Or should we think perhaps completely different, think about inverse proportional assist in some patients with NAVA?
Well, I'm not sure I can answer your question. It's very difficult, and it's an open question for research. I think, and also I missed part of the question with the echo. But it's clear that with the proportional concept of NAVA, they increased their tidal volume. They increased the pressure they received when they increased their drive, which means that the transpulmonary pressure probably is wider at some point, but the notion also of NAVA is that you want to support them when when they need it, so the drive will decrease and the ventilation will decrease. So you have to think that as a temporary, like a recruitment, they compensate and then they will improve and decrease. If they maintain the high drive and they maintain the high support in a proportional way, this is problematic. So you have to, I think that's where you need to check the tidal volume. That's where you need to check the plateau pressure. And I started to do that. In fact, as been shown by CHLA team, it works in NAVA quite well, except if the patient is breathing at 60 per minute and then you don't have a plateau. But even then, you can see the increase in the plateau pressure that reflects what the patient actually received. The problem is that we don't know which threshold is good or not. And it's also an indication, but it's not a direct assessment of the transpulmonary pressure.
I have one question, please. Yeah. I'm a PICO nurse and a ventilation practitioner in University Hospital in Leiden. We don't have the opportunity to measure or have transpulmonary pressure or NAVA. So my question is, I'm very concerned about CIDI in NIF. How can I measure or be concerned that there is CIDI when I don't have all those measurements? We give NIF in the way of with prongs or masks. CPAP, or we give with nose and mouth masks, so give more support. There's a leakage compensation in the machines, and there's a bigger variation in tidal volumes. But how is it just the effort of the patient that you see and observe? Or is there another way just to be concerned that it might be silly?
Yeah, so I think that this is a question that has no answer for now, but I think it's very important to monitor something. And if you do not have the way, and there's no routine way to measure actually the drive in these patients currently, if you don't have ADI or esophageal pressure, which is the case in many places. But at least you know why you put these patients on the NIV. Yeah. So probably he has respiratory effort signs, or tachycardia, tachypnea, oxygenation failure. So look at this, and if the patient does not improve in those clinical symptoms, there might be a problem. You know, if the patient is improving, it's very likely that the drive is improving too. So at least use the tool that you have, the clinical symptoms, and they are quite good. But in the future, that's something we need.
Okay, again, thank you very much, Guillaume, for your fantastic talk.
And it's a pleasure for me to invite again Marcelo to give his talk. And I think it's a challenging topic, so it's mechanical power or driving pressure or respiratory rate only. Because you know all these elements are now in discussion, which is the most causative for inducing lung injury and how is the relationship? Can we keep it simple, let's say, or do we need complex calculations? Marcelo.
Thank you, Peter. Again, very happy because I'm here, and thanks a lot for having me here. So, driving pressure and respiratory rate only, or we need this calculation of mechanical power? So let's do some introduction to this subject. So the driving pressure concept was developed 1 decade ago. And then in this publication, I think we called attention to this concept that was already developed in the last 10 years. But then many papers confirm these results. This is the largest study in adults with 50 countries and also showing a remarkable impact on survival. And interesting, in this paper, there was no impact in terms of tidal volume or plateau pressure. Then new studies now accumulating thousands of patients, and this is possible because of these electronic records and also with recordings of waveforms of ventilator. They have shown that there is a threshold of driving pressure around 12 centimeters of water. So it's slightly lower than we thought before. And I showed yesterday that even in pediatric patients, and this was shown here, so there is also some indication that this is also true. The concept of driving pressure came from this idea that we have to account for this small baby lung. And for instance, this patient with 50% of their parenchyma collapsed, tidal volume cannot be distributed in the same way as in this patient. And then in a very simple mental model, you can think about a patient with normal lungs on the left, and a patient with very diseased lung on the right. Only the medium lobe is patent. Compliance of the chest wall is the same. And then you're putting the same tidal volume to both. And then by simple calculations that you can find in a textbook, you know that the consequences in terms of transpulmonary pressure are going to be different. So if you calculate how much is the transpulmonary here, transpulmonary pressure is going to be 4 because pleural pressure is very low. And here, transpulmonary pressure is going to be 36 because the pleural pressures, in this case, the pleural pressures are very high. So then the transpulmonary pressures are low. In this case, the pleural pressures are very negative because there is very small lung inside a big chest wall. And then transpulmonary pressures get larger. 36 causes lots of damage in all the mammals, obviously in humans too. So you can say tidal volume per se, which is the same, cannot be important. It's important that you size your lung. One way of doing this is calculating compliance, which is proportional to the number of alveoli. If you divide tidal volume by compliance, you have driving pressure. So this is the concept. Sorry for repeating this, but I think this is the concept. So we are normalizing tidal volume. So the same tidal volume is producing completely different consequences in these two patients. It's interesting that even some people from Italy started to develop also the concept of stress and strain, and later on they agreed that driving pressure is a very accurate measurement of stress, because the stress is in the domain of pressures. And let me give you just this example of Chiumello. Chiumello was using CT to calculate the relationship between lung size measured by CT and actual body weight. Terrible correlation, so there is no correlation. When you use ideal body weight, it's a little bit better, so it makes sense to calculate tidal volume according to ideal body weight, not the real one. I know that this is controversial in pediatric patients, but in adults it's very clear, and this is why in pulmonary function tests we use ideal body weight. Then when you try to correlate lung stress with ideal body weight, there is no correlation or a weak correlation. But when you correlate lung stress and driving pressure, there is a good correlation. So even Chiumello, that was a little bit against this concept at the beginning, he did this nice publication. So I think it's a very, let's say, easy, practical way of measuring the stress applied to the baby lung. And also, together with this concept, there was this idea that plateau pressure is not the relevant variable at the bedside. Why? Because if you use high PEEP and then you also have a high plateau pressure, there is a kind of accommodation of the parenchyma in terms of the epithelial cells and the skeleton of the lung. And this is a well-known property of the lung. There are plenty of studies showing this. And this is why I do not believe that we should look at plateau pressure independently. Because sometimes some patients with very high PEEP and even exceeding the plateau pressure of 30 centimeters of water, they can be very well protected. And we clearly demonstrated this in the driving pressure paper. It's similar to this concept that if you're stretching in a very slow pace, there is no problem. In animals, no question that driving pressure is the key mediator. Lots of studies showing this. If we use the same tidal volume in these two conditions, but one with low driving pressure, because you have somehow managed the driving pressures by using proper PEEP, by reducing, trying to, let's say, increase the size of the baby lung, then you reduce injury. And this reduction of injury is also reflected in the PET studies, so less neutrophils in the lung, and also is reflected by less fibrosis, as I discussed yesterday. So there is a negative correlation between the vital capacity of these patients 6 months later and the driving pressure used in the first week of mechanical ventilation. So if this is true in adults, you can imagine that lots of BPD are strongly correlated with driving pressures. And this is interesting because even we took samples of patients when driving pressure was less than 13, there was no production of RNA for procollagen type 1 and 3. And when we used high driving pressure, whatever the, let's say, the mode of ventilation, procollagen in the blood was higher and increased along the week. So clear signal that driving pressure is triggering lung fibrosis. And I showed this example yesterday. Some people now believe that interstitial lung diseases, they are correlated with driving pressure. And it's very nice to see that this patient with diaphragmatic paralysis doesn't have lung fibrosis at the same side in which the diaphragm is not working. But then the strong diaphragm is causing lots of cysts and lung fibrosis, perpetuating the fibrotic process. Okay, then I think we are very, let's say, convinced about this concept, but then something about 8 years ago, Luciano described this concept of mechanical power. And the mechanical power is described by this formula. It comes from thermodynamic calculations. I'm going to give you a little bit more of detail on this. But this formula per se is very complicated, but there is something that is very important, which is the respiratory rate term, which is here multiplying everything. So one of the main components of mechanical power is respiratory rate. And where this idea comes from the idea that the ventilator is delivering some energy on the lung. And this energy has to be dissipated or has to be accumulated by elastic forces. Anyway, it's the total energy produced by the ventilator. We are going to discuss this a little bit further. Okay, some papers have tried to, and some ventilators now, they calculate the mechanical power. And papers tried to analyze in the same way we did for driving pressure, the correlation between mechanical power and mortality. And they found a significant effect, but look at this. This nice paper that launched this concept, I put side by side the correlation between mechanical power and mortality and driving pressure and mortality. You can see, even if I put in the same scale, that the effect, I'm putting this red line on the left to give you some idea, is much weaker. What does it mean? When you have a weaker correlation in terms of mortality and a variable in the x-axis, it means that there are two possibilities. There is more noise in this variable, or the variable is not the key mediator. So in this case, what I believe is that there is too much noise. And why? I believe that mechanical power is a beautiful concept, but the lung is not a thermodynamic machine. There are lots of nonlinear effects. And for instance, the mechanical power formula is putting together lots of parameters that maybe are not relevant to the lung injury process. For instance, I have there tidal volume, and we took a long time to show that tidal volume is not important, and then we are putting back in the formula, and then this is maybe is producing some noise. So this is the thermodynamic idea. So the red dot is, let's say, a certain position of the patient. In the x-axis, you have airway pressure. In the y-axis, you have volume of the lung. So if the patient is breathing with a certain PEEP level, he's going to be moving in this curve. You can see these curves on the ventilators, right? So then you can understand that there are some important areas in this picture here. So the first one is this resistive area, which is the resistive component, which corresponds to the energy dissipated in the airways. Is this causing lung injury? It's very hard to understand how, because this is typically something that is dissipated across the endotracheal tube and main airways. So is this causing alveolar damage? Very questionable. The second component is this dynamic one, which is the elastic one related to the compliance. This one looks like it to be very important, and this is correlated with driving pressure. It's because this corresponds to if you are having a higher driving pressure, this triangle has a higher area. Then we have a much more questionable component, which is PEEP. We are going to talk about this, because if you look at this, the ball is not moving through this area. Why? Because the ventilator is stopping the end expiratory pressure here. So the lung is not submitted to this big area. And when we calculate total power, you are calculating this very big area. But this area is not being applied to the lung. So this is in terms of physics, this concept is wrong. Why? Because this is potential energy. This is not delivered energy. Another important thing to understand about mechanical power is that, there is plastic and elastic deformation. Which is the difference between both? Elastic is something that is conservative. You deliver the energy, and the structure gives you back 100%. Plastic deformation, there is some dissipation of energy. You produce some energy, you deliver some energy, and something is broken in the structure, and then you cannot recover. Very likely there is some plastic deformation in the lung, especially if you have a very large tidal volume. And how can you calculate the plastic deformation? You have to measure hysteresis. You have to calculate hysteresis. And hysteresis is this non-recovered area, which is now in red. This makes a lot of sense. So we should calculate not the mechanical power delivered by the ventilator, but the mechanical power dissipated in the lung, which is this hysteresis area. And there is some very nice papers from Proti trying to calculate this, but it's very noisy at the bedside and has been very difficult. I tried myself, and I could not do it. Now, some people, especially Mojoli, is trying to do it, and I think there is some promise there. But let's talk a little bit about hysteresis, because hysteresis was studied by this Hildebrand, and what they showed is that this area of hysteresis varies a lot if you increase tidal volume. Makes sense. If you increase tidal volume, you have more plastic deformation of the lung. Maybe some structures are broken. But he measured all the parameters related to this area. And guess what? Driving pressure is the strongest predictor of the hysteresis. So there is another very nice reason to believe that driving pressure is also measuring the dissipation of energy inside the lung. Okay, and then because of this mechanical power and this idea that respiratory rate could be an important component of the mechanical power, we decided to test this idea because this makes sense. Whatever you believe in the total power, which I don't, or in the dissipated power, it makes sense to think that the repetition along the time makes a difference. If I hammer this table for 100 times or 1,000 times, maybe 1,000 times is going to be worse. And so respiratory rate must have a role, and then we reanalyzed our data checking the role of respiratory rate. And then we had a larger sample of patients, almost 5,000 patients, to check this question. We had baseline variables to adjust for severity of disease, to take out the severity of disease. And then we checked, is respiratory rate after adjustment for baseline disease related to survival? Yes. Is tidal volume? No. Driving pressure? A lot. PEEP and plateau pressure? Not in this sample of patients, because there was a mixture of different levels of PEEP, and then in total there is no effect. But driving pressure and respiratory rate, independently, they are related to the survival of those patients. Okay, all these parameters, they make part of the mechanical power formula. So let's lump together everything and check, is mechanical power using that formula related to survival? So I'm replacing all the single variables by the formula. Then, yes, there is some correlation. But the key point is that is an independent information or is just, let's say, another information? So what you have to do is now take these variables and then, so I have now these simple variables, and now I'm going to check, is mechanical power adding additional information here, is adding some further information, and then if I do a multivariate model where these variables are already in, power is not. So there is no benefit in getting this information. I calculated this information if I have already the original ones. And then I can neglect those non-significant ones, and I can take just the respiratory rate and driving pressure, which is much simpler to use at the bedside, because these are variables that I know that the respiratory rate now is 20, and later on is 30, something very simple. So if I have a respiratory rate and driving pressure, I don't need mechanical power. This was replicated by the Boston team. They had this, exactly the same result now with 100,000 patients. Okay, then the power components, you can split the power components in the resistive, static, and dynamic, and whatever you take it doesn't work. And in fact, the resistive has kind of negative impact. Maybe because if you have obstruction or high resistance, you are protecting your alveoli, I don't know. So there is no additional information here. And then just looking at quintile analysis, I like quintiles because they give you some ideas of thresholds. For instance, for driving pressure, you can see that this is driving pressure in the x-axis, and this is relative risk of death. Looks like there is a threshold in quintile 2, which is when driving pressure is around 12 centimeters of water. So there is a threshold, and then mortality increases. For power, there is no correlation with survival. So again, there is no additional information. So I'm taking 2 by 2 variables because it's very interesting to understand the meaning. Now, driving pressure against respiratory rate, both are relevant. So when I combine both variables, I have more information about the prognosis of the patient. So I think for me, this was the important point of this analysis. So if I compute respiratory rate, I know a little bit better if this patient is going to die. If I take tidal volume, no additional information. And this is the reason why calculating power produces noise, because tidal volume is an important component of power and has a lot of noise, because a larger tidal volume or lower tidal volume for the same driving pressure doesn't matter. And then we did the mediation analysis, and the mediation analysis, I'm not going into the details, but it showed the same thing. When you decrease driving pressure, your survival improves. If you increase the respiratory rate, your survival is worse. And if I try to understand which is the role of tidal volume, there is no role. And mechanical power, also no role. So the only mediators of mortality are driving pressure and respiratory rate. Okay. Now, one important question. When we see the size of the effect, because this is, for clinicians, this is very important. Which variable is more important to consider at the bedside? And I'm going to ask you a question in which the effect size is going to be very important. So just to know, driving pressure is these dots, the black dots, and respiratory rate is the white squares. And in the y-axis, we have risk of death, In the x-axis, we have standardized values of the variables. But in fact, you can think that the lowest respiratory rate here was about 15, and the highest was 40 breaths per minute. For driving pressure, the lowest value was 5 to 7, and the highest was 40 to 50. And then you can see, if you walk through this range of a variable, how much your mortality increases. And you can see here, walking through the whole range of respiratory rate increases your mortality by twice. But if you do it by walking through the whole range of driving pressure, increases your mortality by 6. Which means that there is a 4 times scale. So driving pressure is 4 times more important for mortality than respiratory rate. And why this is important? Because then you can make this clinical question. Is it worth to decrease tidal volume by 20% if I want to keep the same PCO2, and thus I have to increase my respiratory rate by 20%? So you can calculate now if this maneuver is worth to be performed at the bedside. And then I'm not going into the details of this calculation. You have to assume some constant CO2 production. But we can prove that this depends, the response to this question depends a little bit on the compliance of the patient. If the patient has a low compliance, for instance, the patient has a driving pressure of 27, then I'm going to decrease tidal volume and increase respiratory rate at the same time. Now my driving pressure is 21, but my respiratory rate is 45. What happened with my mortality? Yes, this was beneficial. It was good to do this. But then in this patient that has a better compliance, now my driving pressure is 12, and if I want to decrease it further, I got to 9 of driving pressure, but now my respiratory rate is 40, and my mortality increased. So it's very interesting. We created a web calculator. Unfortunately, it was removed from the website. I have to put it there again. So you can, at the bedside, calculate this risk. And then for your patient, you can know, oh, is it worth it to do this maneuver? And I'm not going to the details of these calculations. And then, one last point that for me was very important. We tested, this kind of calculation for me was very interesting to extrapolate to high-frequency oscillation, right? Because in high-frequency oscillation is a typical situation that you are trying to minimize as much as you can your driving pressure, but then maybe we are increasing too much the respiratory rate. And this is really something that I think this kind of approach could be very, very useful. So let me, ultimately, what we have to do in the future is to do PET studies, because I think it's the only way to move forward into this question. But there is also another approach that I want to propose you. For instance, in this case, we increased respiratory rate. So the animal was like this. We increased the respiratory rate, but decreased the driving pressure. Sorry, the other way around. So we decreased the respiratory rate and we increased the driving pressure, and then this was not good for the animal. So it got more inflamed. We did lots of combinations trying to understand this role. And I think PET studies is the final solution for this. But then this would require a big number of animals. And we could not finish this study. But it was interesting that the initial results, they were very consistent with our hypothesis that driving pressure was more important than respiratory rate. But when we moved to very high frequencies, the results were not that consistent. Okay? So I'm not sure what happens with high-frequency oscillation. So this is a big question for the future. Just to give you some more, let's say, intuition, this is a typical ventilation. Are those nice alveolar films produced by Gary Neiman of conventional ventilation, and this is high-frequency oscillation. It's interesting to see that, yes, the walls of the alveolar sacs, they are moving very little, but some alveolar are closed and stay closed. And to tell you the truth, this movement was not so small as I was imagining. This was 10 hertz, and I was imagining that the movement in the wall should be a little bit smaller. So this is why I believe that now with EIT, we should get together lots of data in these patients with high-frequency oscillation. Let me just, this is going to be very quick. Let me just show you something very interesting. Peter, I'm done with the time, or how much? It's okay. Yeah, it's not going to take more than 5 minutes. Look at this. This is an animal, 5 hertz. Now we are going to increase the frequency, 10 hertz. The pattern changed completely. You see now you have very little ventilation in the dorsal part of the lung, and you have this kind of Pendeluft. Pendeluft means that some regions have a very different time constant. And very likely the air is entering first in the ventral regions and later in the dorsal regions. And this is a problem because then it means that some regions, they can get overstretched during inflation, like the Pendeluft. The problem of Pendeluft when we have a strong diaphragmatic contraction is that the dorsal regions, they get overstretched twice or 3 times more than during paralysis, because during the inspiration, you are getting the tidal volume for the dorsal region coming from the ventilator and coming from the ventral region. So you are having double tidal volume for the dorsal region during inspiration. And then during the end inspiration, this air comes back to the ventral region. So if you have this kind of pattern, temporarily during inflation, more air goes to the ventral region to be redistributed later to the dorsal region. So you are kind of overstretching a little bit, in this case, the ventral region. A very recent experiment that we did in our lab, before putting the animal in high-frequency oscillation, we tested how this animal works. It was a small piglet, 5 kilos. We did a PEEP titration, and then this animal needed a PEEP of 8. So the crossing point between collapse and overdistension. So clearly, at a PEEP of 8, there is no collapse. At a PEEP of 6, you start to see clear signals of collapse. Pay attention to a PEEP of 80, lots of overdistension. 46% of the parenchyma is completely overdistended at a PEEP of 80. Okay. Then we started to do high-frequency oscillation, and it's nice with EIT that it's very easy to decompose the 2 components, the slow component of the spontaneous breath and the fast component of the high-frequency oscillation. So you can decompose both components, and this patient was, we started with 7.2 hertz. And I think this is very common if you don't paralyze your patient during high-frequency oscillation. But look at this. We are concerned about this distribution, but the tidal volume of the patient is twice the size of the high-frequency oscillator. So this is another question that I don't have a solution for this, but we have to start thinking that should we care about the component of the high frequency or the component of the spontaneous breath? I don't know, but we have never measured this before. So maybe we have to measure both and start to compute the total sum. Now this patient is only under conventional ventilation, and we started to use high-frequency oscillation. It's interesting because this ventilator, I was using the Draeger ventilator. It starts to accommodate and until the point that it delivers the target tidal volume. So it's increasing the tidal volume. here is just for you to have an idea how much is the tidal volume of the high frequency compared with conventional, but you are going to be surprised very soon. Now, we move to this screen because we can understand a little bit better what is going on. Sorry, because we removed the pneumotech. And now there is no spontaneous breath because the animal was paralyzed. And what I see here is just cardiac oscillations. So the slow component is cardiac oscillations, the fast component is the high frequency oscillation. Okay, now high frequency. Now let's move back to conventional ventilation. Now it's conventional ventilation. Look at the size of the tidal volume here in the platysmal graph. It's about the same. So depending on the settings you are using during high frequency oscillation, your conventional ventilation is not that different, but you are doing this 100 times per minute. This cannot be good. So I think this whole analysis about which is the best frequency and the effective driving pressure and the tidal volume for this patient has to be reconsidered completely during high frequency, and we need better monitoring. One final slide. How we can measure driving pressure during high frequency oscillation. I have a proposal, and I hope we can collaborate in multi-center studies or some even bi-center studies using this approach, because this is the approach we did for the original description of the Pendeluft. So we were interested in understanding how much driving pressure is applied to the dorsal regions. And we measured using a special piezoelectric sensor in the pleural cavity, which is shown here. And then we measure for each situation. So what happened in this graph is the following. The animal was having spontaneous breaths. The total driving pressure was 22. Take the black dot. Then we paralyzed the animal. Now I have only ventilator, no diaphragmatic driving pressure. So tidal volume and the transpulmonary driving pressure dropped. And then I started to increase the pressure control ventilation until the point I got exactly the same driving pressure for the dorsal region. And then I said, aha, if I'm applying 25, I have to apply 25 of pressure control to get back to the same transpulmonary driving pressure. I can use the same rationale to do it during high frequency oscillation. For instance, if I have a pixel, it has an oscillation of this size, then I paralyze the animal, and I try to get the same oscillation using conventional ventilation. I can check how much driving pressure I need to move this pixel in this direction. And this graph is showing you that this corresponds very much to what is happening at the regional level, because we put pleural sensors in different parts of the lung. So you take the size of the oscillation, you paralyze the animal and try to produce the same size of oscillation during conventional ventilation, and then you can measure the driving pressure. I think this is the solution, and we should be doing this in some patients that are paralyzed. This is very easy to do, and then we can start constructing this nice rationale like we did for driving pressure and respiratory rate, but here in the x-axis we are using hertz. I don't have any idea if this graph is okay, but we have to understand what to do with high-frequency oscillation. I think it's a key question. I would like to move forward in this direction. Thank you very much.
Thank you, Marcelo. I think this presentation was one side a relief for all of us, so no calculation mechanical power, just driving pressure and rate, which is interesting. And the second part is challenging, especially for pediatricists. I like to do high-frequency oscillation. I think there are many questions still there.
Lots.
So just one question. I mean, we advocate very high frequencies in order to have a lot of pressure amplitude damping. which means in the periphery we have small delta pressures. At the end, there would be small driving pressures for the parenchyma or on the liver level. In the adult, I saw you working with 480 per minute, which is 8 hertz. And in Martin Kneiper's publications, they show 12 to 15 hertz easily in pediatric patients. And in neonate, nowadays, we tend even to go higher if the machine allows. Oh. Do you think about this, or do you, since you work in adult, just think beyond 8, that's not feasible?
You know, this is a very, very important concept. I tried to show these images for 2 reasons. First is that absolutely true. I think it makes a lot of sense trying to move to the highest spectrum of frequency, because then you can reduce as much as you can in terms of driving pressure. But there are 2 caveats. The first one is that in conventional ventilation, the respiratory rate matters. So if you are decreasing the driving pressure and you are increasing the respiratory rate, how is the balance? We don't know yet, and I'd like to have that curve. The second caveat is that when you use very high frequencies and you have an imbalance in time constants, you start to have a baby lung inside the baby lung, because then it's a baby lung caused by resistance, not by compliance. So all the air goes to the open channels and not the compliant units. And then, so you start to have a different part and this kind of pendulum. So we have to start measuring and to understand what measures when we increase the rate. For instance, I have the feeling, it's just an impression, that because in the same day I had a big animal and a small animal. In the big animal, whenever I tried to go above 5 hertz, the images started to have pendeluft, and I started to see a baby lung inside the baby lung. But in the small animal, maybe because the time constants were faster, I could go to higher frequencies and very homogeneous. So I think we have to individualize.
But to follow up on that, doesn't the degree of how you recruited the lung with your frequency play a role? Because I can imagine that if you have set low pressures, you may see more pendeluft than when you have, let's say, fully blow up the lung.
Absolutely sure. Recruiting changed completely, the movements, and proning also. So these are 2 areas very interesting, because then, especially what I saw is that low PEEP, supine, the air goes first to the ventral and later to the dorsal. But then if you put the animal in prone, you sometimes could reverse a little bit without changing PEEP. Yeah.
Yes, please, Flora.
Yeah, thank you for this excellent talk. Tobias Werther from Austria. We as neonatologists, we usually use volume guarantee ventilation, so on. And nowadays we start to thinking much more also in the direction of this driving pressure. Should we reconsider these studies again and looking into them more carefully? How much was the driving pressure in these studies? And should we probably, well, question again what are the more protective modes then?
I really think so, and especially because, you know, the Anglo-Saxon people, people from England and United States, they have this straightforward, I think, simplistic idea that volume controlled is very good also for assisted ventilation, because they don't care about synchrony, but they care about controlling tidal volume, because this is an indirect way of controlling transpulmonary pressures. But I think if you read the papers from Takeshi Yoshida, he showed that even in volume control, you have pendeluft. So you have these local forces that they completely abolish this rationality. So I think, so then even this idea that you are conserving or putting some boundaries in transpulmonary pressures because you are controlling tidal volume, they are not true. So I really prefer that you allow to get a better synchrony and then you measure your driving pressure. Felipe?
Hi, Marcelo, thanks for your talk, and for Guillermo also. We're neonatologists or pediatricians. Our patients breathe more frequently than an adult patient. That's the baseline. And when we're not correctly titrating the level of support, we're going to be dealing in situations like this, that you have collapse, and maybe that's part of the PPD history that we have not seen solved yet. So my question is, how do you figure that, how can we manage those patients at the bedside? We just had a prior question mentioning sometimes we don't have VIT, we don't have esophageal pressure, so how do we see this? Are we going to go only clinically, or are we going to need real new devices and spend some money on this to get better results? How do you imagine this in the next period?
I'm a little bit biased because I'm very pro monitoring, and I think it's like I like to say that if there was no telescope, there would be no physics. And I think if we don't have instruments to measure at the bedside, we are not understanding what is going on. And I think we spend, let's say, one treatment of antibiotics is the same of one new device to measure something in the patient. So I think we should think a little bit better about this. I think without monitoring, we cannot move forward. This is my bias, and I'm biased in any aspect. For instance, when I saw the presentation about continuous CO2, even if it's not accurate, I love it because it's one more piece to do these transitions. And I think we need, I think we can change this. I really believe.
Thank you so much for this fascinating talk. My question would be about patient with unilateral disease. I mean, these patients are very challenging to manage, either conventionally or oscillator. What your thoughts and strategies in managing these patients safely, and what will be the use of AIT in titrating these patients in terms of PEEP or MAPS?
I didn't have the time to show the titration of the mean airway pressure, but it's also something that can be beautifully done. Even if you don't, you can, something that for me was very interesting is that I made it PEEP titration during small tidal volumes, conventional ventilation, and then during high frequency, I got exactly the same results. Below a certain PEEP, the dorsal part starts to collapse, and there was a correspondence with mean airway pressure. Typically, mean airway pressure has to be 5 to 6 centimeters of water above the critical PEEP, more or less. Depends on the size of your, the amplitude that you use in the oscillator. So the same principles, but in fact, the question that was raised by the chairman, that when you have more heterogeneous lungs, you have more Pendeluft, and you have this kind of concentration of tidal volume in one part of the lung. If you titrate mean airway pressure, you can abolish this. And I really believe that we should be doing this. And I didn't have the time to show that if you're using this animal that I was showing here, a mean airway pressure of 15, this animal was completely overdistended, completely. And this is why, again, these protocols with fixed numbers for mean airway pressure, they cannot work. I think it should be, and I don't believe in using oxygenation for this. Oxygenation is a very bad target to follow because of this dissociation between mechanics and oxygenation. And then I really believe that we should be monitoring in different ways. I bias towards EIT, but I think is what we have for now. Maybe esophageal pressure can help us also. I strongly believe in this.
With patients with like one sick lung and one good lung, do you use the same strategies as well?
This is typically what I try to do. We have only one PEEP and one mean airway pressure, but what you can do, you can play with pleural pressures, because then you can, for instance, if you put the bad lung upwards, your transpulmonary pressure is going to be higher here, and it can be a lot. It's we put some sensors, and also we measure how much FRC, or end expiratory lung volume, you gain by using lateral position, for instance. And sometimes you get surprised that this lateral shift is equivalent to giving plus 10 centimeters of water of PEEP to the non-dependent lung. So it can be a lot. So I think we should play much more with positioning, knowing how the lung is working.
Thank you.
Yeah.
Thank you, Marcelo. I think we could stay for hours and discuss together, but it's coffee time. Do not forget, in 50 minutes, poster walks in the exhibition area and some oral presentations here, the pediatric, and upstairs the neonatal oral presentations. Thank you.
Da muss jetzt einiges neu denken.